UroPatient. Tune in and see. Prepare your health for you and me. Knowledge is power. We make it clear every Saturday morning.
Hey, good morning and welcome to the UroPatient podcast. I'm your host, Vic Senese. Glad to have you on board. If this is your first time checking us out, be sure to like and subscribe. Helps us out on our show. Hey, today we're tackling a question that thousands of men and couples ask every year. Can a vasectomy be reversed? Many men choose vasectomy as a permanent form of birth control, but life circumstances can change. Whether it's a new relationship, a desire to expand your family, or simply reconsidering a previous decision, understanding your options is important. Joining us today is an internationally recognized men's health and fertility specialist, Dr. Landon Trost. Dr. Trost will explain how vasectomy reversal works, who may be a good candidate, and what factors influence success rates, and what patients can realistically expect before, during, and after the procedure. We'll also discuss alternatives to vasectomy reversal, common misconceptions, recovery expectations, and the latest advances in microsurgical techniques that are helping more couples achieve their family building goals. If you've ever wondered whether a vasectomy can be reversed, or if you're considering reversal yourself, this is an episode you don't want to miss. So welcome to UroPatient again, and let's get started.
Very pleased to be able to talk about male infertility in general, as well as vasectomy reversal, and specifically emphasizing some of the psychological aspects of this and the kind of this concept of science of second chances. I don't have any relevant disclosures for this particular talk. Well, just high level, quick background. So, like it was mentioned, I did a fellowship in andrology, which is basically the study of men, and that's kind of goes through the infertility side of things, the sexual medicine side of things. I then served as an andrologist at Mayo Clinic, and now have a practice that focuses specifically on Peyronie's disease and vasectomy reversals. We do a high volume of vasectomy reversals. So when you look at the largest publication ever on this topic, it has about 4,000 cases that were performed over a period of roughly 40 years. But in contrast, we do about 1,200 per year. So we do a real high number of these types of procedures. So it helps in being able to try to discover new things or solve some of the problems that are existing and out there. Now, just some basic stats on reversals themselves. So there's a little over 500,000 vasectomies performed each year in the United States. When you think about that, that's a huge number. Despite that, about 20% of them experience some degree of regret at some point and consider undergoing a reversal. And that can be due to various things. It could be an unstable relationship. It could be men who are under 30 are more likely to have a desire to undergo a reversal at some point. Sometimes they don't have kids when they have the vasectomy, or very young kids. Sometimes it's related to complications of pregnancy, or it can even just be a financial crisis, as much or more than anything. So that brings up this question. So, what percentage of men, and this is just rhetorical, but what percentage of men that desire a child post-vasectomy actually do a reversal? And, is it anywhere from less than 5 all the way up to more than 90? In reality, it's less than 5% of those who want a reversal will actually do it. So that begs the question, well, why? Why is it so low compared to all those who are desiring with it? A big part of it is just unaware. It's very common among patients and physicians that someone will say, oh, it's permanent. You can't undergo a reversal. This is meant to be a permanent procedure. Or sometimes people want a faster pregnancy. They want to do IVF and get pregnant that month. There can be not that month, maybe the next month. There can be female factors that are involved. It could be a perceived cost, or some men just don't want to have surgery in that area of the body. In fact, I'd say all men don't want to have surgery in that area of the body. And a little side note there, technically all, whether you do IVF or reversal, you need surgery in that area to get sperm out. So I just wanted to go real high level here of looking at your two options after you've had a vasectomy. You can either do in vitro fertilization, or you can do a vasectomy reversal. So when you look at the two, so on the left is just an illustration we did at Mayo that shows kind of the concept of a vasectomy reversal versus IVF. IVF itself is somewhat involved. You have to do some medications on the female side that get the ovaries ready to basically generate multiple eggs. You then retrieve the eggs. Externally, you can take the eggs out, you put them in a dish, you fertilize them or directly fertilize them through something called ICSI. You then culture it up for a period of time, transfer the embryos back into the uterus, and then confirm whether or not a pregnancy occurred with it. And usually one cycle of IVF, like I mentioned earlier, is about 2 months when you do kind of start to finish, when you start the whole process. And when you compare that on the male side, what do you have to do for IVF? Well, you have to retrieve sperm, and there's different ways you can do this. You can do what's called a TESE or a MESA or a vasectomy reversal that then can get sperm out through the ejaculate. And these are surgical procedures, all very minor, where you are able to retrieve sperm for it. Some of the newer technologies over the past couple of decades include what's called ICSI, or intracytoplasmic sperm injection, where you can take essentially a really tiny needle and inject a single sperm into an egg. Or you can just put the egg in a dish, put sperm around it in the more traditional IVF type approach. Either of these are viable depending on the certain circumstances. These then grow up, and you can see under a microscope here what the egg looks like at different times once it's fertilized and turns into a blastocyst, the different stages. Day 5 is about the time when you start to make a final decision as to whether or not to implant. Vasectomy reversal, so just a little quick animation here of what that entails. And this is, of course, a little bit cleaner than in reality. Digital animations always, brush up some of the details on it. But so you make your incision to get down to the prior site of the vasectomy. And you can do this different ways, but once you remove the area of the prior vasectomy, you'll then sample the testicular end of the vas deferens. And if you see swimming sperm, then you can just attach vas to vas, as will be shown here. If you don't see swimming sperm, then you have to do what's on the right side here, where you attach the vas to the epididymis. So it's a little bit more involved of the process overall. You then sample it to make sure that you are indeed attaching 2 sperm, and then you can put that back together, put the testicle back in the scrotum, and then restore everything the way it was, close up the incision. So overall, this is about a 3-hour surgery or so, anywhere between 2.5 to maybe 4 hours, kind of depending what has to be done complication-wise. Well, there's advantages either way. So on the in vitro side, this is faster, as far as faster per attempt, because within 2 months, you're going to know whether or not that cycle worked. It's also very good for schedules. If you have someone who has a real tight schedule, has to be pregnant on certain months, IVF is definitely the better way to go. It has a very limited role on the male side. Once you get sperm out, they're essentially done. There's not anything more that needs to occur there typically. And sometimes you have to do IVF. So certain scenarios on the female side may require IVF with no real options. Vasectomy reversal alone wouldn't be able to accomplish those same purposes. You can also do pre-implantation genetic testing if there is a certain genetic trait that you don't want to pass on to kids. IVF has that ability. And typically, when you look costs, you're looking about $15,000 to $20,000 for the first cycle and $5,000 to $8,000 for each additional cycle, as far as when you don't have to do a complete new from the start. And that's in addition to the male side. For reversals, they are a little bit less invasive and they're less risky on the female side. They definitely are more cost effective because they'll be anywhere from $2,000 to $12,000 for the reversal versus $15,000 to $20,000 for IVF. You can have children naturally, so just through natural intercourse, and you can have multiple children with just a single procedure. And overall, if you say, what are the success rates with a single procedure, they do have a higher success rate when you go to someone who does a lot of these or have high volume centers. Now, success rates on the IVF side, there's a great website called SART, so it's SART.org. And you can go there, and this is a little bit older page. They, of course, change it often, but then you can go to this IVF success section, and you'll be able to type in your zip code, and it'll show you the anticipated success rates depending on where you're living. And this is what the page will typically look like, and it'll break it down by age of the female partner, and they'll look at overall live births or just singleton births, so single birth. And you can see live births per intended egg retrieval all the way down per, these different options. And you can see that it's heavily age dependent. So if you're over 42, you're looking at roughly a 3% chance. And this is just one particular center. So every center is going to be a little bit different. Versus if you're under 35, you're up to 42% chance of live birth. Now, how about reversals? So this was from one of our recent studies where we did a randomized control trial looking at different medications you can use to try to optimize outcomes. And you can see the pregnancy rate. Now, these were women under 35. So again, if you're comparing it to IVF, you're looking roughly 40s, maybe 50s. Success rate here. Pregnancy is going to be in that kind of 60 to 70 range. We're looking specifically at the control and prednisone low groups. These other ones we learned you don't want to do, these particular therapies post-reversal because of how they impact outcomes. But you can also see there's different ways of tracking success. So what's the likelihood of patency or having sperm at any point? And that's roughly in the kind of mid to upper 90s, kind of depending on which study and which group. And depending how high of a concentration you look at, your success rates can vary from that too. But again, overall pregnancy is kind of the key thing people are looking at when they're doing a reversal. So again, patency, depending on the study, will range from 70 to 99. Pregnancy will be anywhere to 22 to 72%. And their outcomes are heavily variable, highly variable. It depends on if the surgeon can do what are called EVs or epididymostomies. Depends on the surgeon volume, the technique you use, post-op protocols, and which data people are excluding when they're publishing their results. It also depends on time. If you're 30 years out from your vasectomy, then the likelihood of needing these more complex repairs goes up, and the overall chance of sperm coming back is going to go down. Whereas if you're 5 years out, you've got a much higher chance of success overall as far as long-term sperm counts, for example. And again, this just highlights two different approaches for performing these types of repairs. And like I mentioned, the longer it's been, the overall total motile sperm counts will go down just because this testicle scars up a little bit the longer it's been since you've had a vasectomy. And that's shown in a couple different ways. You've got this graph, then you show the same thing over here. This is an older study that showed that their pregnancy rates did decline the longer it's been since someone has been out from their vasectomy. And that does vary depending on the study itself. All right, surgical procedure. So for pre-op, there's not a ton required for a reversal. You just need to make sure that you can limit your activities afterwards. If you're in the military or in law enforcement, things like that, and you have to be real active, it's not going to be great to do a reversal because you're just going to rip it apart. You also want to make sure you're off of testosterone for at least 6 to 12 months, ideally, or even longer if you can. You need to be ready to achieve a pregnancy right away, and you want to make sure that, at least on the female side, there's no clear known risk factors if you can avoid them. Procedure, it's about anywhere from 2.5 to 4 hours is typical. It can go all the way up to 6 hours in case of real complex cases. Anesthesia can vary, so you can do it just with numbing medicine alone. You can give oral sedation as well. You can do IV sedation, or you can do the full general endotracheal type intubation. If you do some of these top ones, you can actually eat during the case. You can watch TV shows, things like that. So it's not a real high risk type procedure. Post-op, we recommend that people act like a sick 80-year-old man for 2 months, just to really limit your activities. We tell people they really need to focus on trying to get pregnant right away, even that first month, just in case it does scar down later. We also recommend saving up the ejaculate for the first few months in particular, and only ejaculate around the time of ovulation. So don't skip the first month, but only ejaculate when it's around that time of ovulation. We also tell people to be real careful of sexual positions the first 2 months because you don't want to rip anything apart. And again, prednisone, our latest data says that prednisone likely has a significant long-term benefit in preventing long-term scarring down. And that's shown by this study. So again, this was that randomized trial that showed if you did this low-dose protocol of prednisone, your pregnancy rates were just as good long-term, but importantly, your long-term sperm rates or your sperm concentration was better compared to if you didn't do it. And we followed the study all the way out to 3 years, and I don't have the data presented here yet, but there's a greater and greater separation that we see in sperm counts of those who did prednisone versus those who didn't. And again, this is shown when you look nationally. We did a study where we anonymously got data from different surgeons from around the country. And it was quite surprising when we looked at the difference in outcomes depending on surgeon. And these are all high volume, experienced, fellowship trained surgeons who do a lot of reversals. And you can see you've got, this person's up in the 15 million at, 7 to 10 months sperm count range, whereas these people are down in the 0 range. So really quite a dramatic difference depending on technique and volume. Overall, we saw that concentrations did decline over time. Just people tended to scar over sperm count wise. Whereas again, that's highly variable depending on the surgeon themselves. If a repair is unsuccessful, you can always redo it. So they have similar success rates to a first-time case. You can't always do that if you had to do complex repairs before. You can also do IVF. And this often does become a numbers game, where sometimes you just have to throw a couple things at the wall and then eventually, to be successful. It's also very important to set expectations that it's not always a one and done type thing with either IVF or reversal. Sometimes you have to do a couple things to be able to achieve a pregnancy. Not a lot of complications post-reversal. You can get a bleed or a hematoma. You can get infections. You can get chronic pain, but none of these are very common. All of these, of course, are going to be higher if you're doing a redo type reversal or an epididymostomy or these more complex type repairs. All right, I just wanted to end on these psychological aspects. These are some of the more interesting, pieces that are related to infertility in general. But psychological aspects with infertility are definitely significant. I think it's really tough to understate how significant these can be. But when you look at these, is it a female thing, a male thing, or both? And when you look at anxiety, so the way you read these types of figures is we've got women over here, men over here. If the data are more on this side, that means it affects women more. So when you look at how much does infertility affect women, and this is individual studies, each one of these are an individual study, you can see clearly it affects women much more than men overall. And that's true with depression. So again, you see that, there's an occasional study that'll say men get depressed more than women with infertility, but clearly the numbers overall are heavily in favor of women. Stress, so stress-related infertility, it affects women more. Self-esteem, now this is actually better in the sake of men here, so it shows that men will have higher self-esteem as it relates to infertility compared to women. Now, granted, there's only 3 studies here, but they do appear to say that women experience lower self-esteem as it relates to infertility. And so you'd say, okay, well, good, at least one of the 2 in the couple, is doing well. But as everyone knows, in a couple, it's 2 people. What affects one person affects the whole couple. And so then it rounds it out of, well, does counseling have any, significant role here? And without a doubt, counseling has a dramatic impact on couples undergoing infertility. Now, this isn't necessarily couples that are struggling in their relationship or anything like that, but all that data I just showed you highlights how this affects the couple because it significantly affects, in particular, on the female side of it. And so if you look at, well, if you counsel during this time, so during infertility, it'll improve not only marital satisfaction, but sexual satisfaction as well by quite a bit. So these data show that this is a real strong effect that counseling can have on improving the relationship during this time.
Well, there you have it. I hope that was helpful. Thanks again for Dr. Landon Trost. Great explanation about vasectomy reversals. And this is a guy who's the super expert in the country. So, hey, next week we've got on UroPatient, we take a topic surrounded by curiosity, confusion, and plenty of misinformation. Penile enhancement. What works, what's safe, and what to avoid. In next week's episode, I'm going to break down the facts behind the most common advertised treatments and procedures and supplements, and separate evidence-based medicine from hype and risk. From pills and pumps to injections, devices, and surgical options, this episode focuses on honest, practical education designed to help patients make informed, safe decisions without stigma. For information, if you've ever had questions about male sexual health, body image concerns, or enhancement options, you don't want to miss this episode. So be sure to check that out next week on UroPatient. And as always, check us out every week for all of your urological needs. I'm Vic Senese, and this has been UroPatient Podcast.
From research updates to daily advice, Vic explains it all simple and precise. No question too small, no topic too wide. We're your urology partner, right by your side. UroPatient, tune in and see, paving your health for you and me. Knowledge is power. We make it clear every Saturday morning. The podcast is here.